So we're talking about meeting the safety needs of the older adult. Your lesson outcomes are as follows. Safety concerns often present due to physiological changes in the elderly. Diminished range of peripheral vision, often due to glaucoma, and changes in depth perception are common and can interfere with the older adult's ability to judge the distance and height of stairs and curbs or to determine the position and speed of motor vehicles. Older adults are 10 times more likely to misjudge depth and fall. Central vision losses may occur due to macular degeneration. Decreased auditory acuity reduces an older person's ability to detect and respond appropriately to warning calls, whistles, or alarms. Safety is a major concern when working with or providing care to older adults. The CDC reports that over 41,000 older adults died from unintentional injuries in 2010. The largest number of accidental deaths in the older adult population by a wide margin are from falls, the risk of which peaks sharply in the 9th decade of life. Motor vehicle accidents and choking also claim many lives of older adults prematurely. Falls, choking, poisoning, burns, and automobile accidents are the most common safety problems among older adults. Exposure to temperature extremes also place older adults at risk for injury or death. Older adults are more susceptible to accidents and injuries than are younger adults because of internal and external factors. Internal factors are specific to the person and include normal physiological changes with aging, incidence of chronic disease, use of medication, and cognitive or emotional changes. External factors are specific to the environment and include factors that present hazards to older adults, such as poor lighting or a slippery floor. Vision and hearing are protective senses. When the acuity of the senses diminishes, the risk of injury increases. Vision and hearing changes are common with aging. Diminished range of peripheral vision and changes in depth perception are common and can interfere with the abilities of the older adult. The sense of smell and taste also help protect us from consuming substances that might be harmful to the body. Decreased sensitivity of these senses increases the risk of accidental food or chemical poisoning in the older adult population. Conditions affecting the cardiovascular, nervous, and musculoskeletal system are also contributors to safety problems. Cardiovascular conditions that result in decreased cardiac output and decreased oxygen supply to the brain can cause the older adult to experience vertigo, which is a dizziness, or syncope, which is fainting. Common disorders with this result include anemia, cardiac arrhythmias, and orthostatic hypotensions. Studies have shown that approximately 52% of long-term nursing home residents older than age 60 experience 4 or more episodes of orthostatic hypotension every day. Amazing. Older adults with neurological disorders such as Parkinson's disease or stroke experience weakness and alterations in gait and balance that increase the risk of falls. Neurological and circulatory changes can also decrease the ability to sense painful stimuli or temperature changes, increasing the risk for tissue injury, burns, and frostbite. A study has shown that nursing home residents with diabetes are more than twice as likely to suffer from falls as those who do not have diabetes. Musculoskeletal conditions such as arthritis further reduce joint mobility and flexibility, decreasing the ability of the older person to move and respond to hazards and intensify the likelihood of accidents or injuries. Adults often experience one or more physiological changes that increase their risk for falls and other accidental injuries. Any of these changes alone or in combination can reduce the older person's ability to respond quickly enough to prevent an accidental injury. When these problems are combined with chronic disease or health problems, the risk increases dramatically. Common physiological changes that affect safety include decreased mobility, decreased flexibility, decreased muscle strength, slowed reaction time, gait changes, difficulty of lifting the feet, an altered sense of balance, postural changes, sensory deficit, lack of knowledge of health practices or safety precautions, being in a hazardous environment, and a history of accident or injury. Medications often contribute to falls. Because older adults commonly take one or more medications, their risk for untoward effects is increased. Any medication that alters sensation or perception, slows reaction time, or causes orthostatic hypotension is potentially dangerous for older adults. Common types of hazardous medications include sedatives, hypnotics, tranquilizers, diuretics, antihypertensives, and antihistamines. Alcohol, although not prescription medication, acts as a drug in the body. Alcoholic beverages, particularly in combination with prescription drugs, increase the risk of falls and other injuries. Falls are the most common safety problem in older adults. We've said this multiple times. Consider the following statistics. Falls are the leading cause of both fatal and non-fatal injuries among older adults. Approximately 30% of people older than the age of 65 who live in the community fall each year. Any fall is the best predictor of future falls. What that means is if I fall, I have an increased likelihood that I will fall again. 2/3 of those who have experienced one fall will fall again within 6 months. Fear contributes to this risk, as the person who has fallen may reduce their physical activity and physical fitness out of fear of falling. The older the person becomes, the more likely he or she will suffer serious consequences, such as a hip fracture or traumatic brain injury from a fall. Falls are the leading cause of death caused by injury in people over the age of 65, and number one for men over 80 and women over 75. Approximately 1/4 of older adults who experience a fall will die within a year, and another 50% will never return to their previous level of independence or mobility. The incidences of falls are higher among those residing in long-term care facilities than among those who live independently in the community. 95% of hip fractures are caused by falls. The cost of falls reaches $30 billion in 2010, and of course that's increased in the last couple of years. Many independent older adults are reluctant to report a fall because of the implications that they are frail and dependent. In addition to causing bodily harm, falls take a psychological toll on the older adult, causing them to lose confidence and decrease mobility. We've already said this. This is unfortunate because early recognition and intervention can reduce the risk for further falls. Older adults living independently in the community often do not recognize hazards in their home, those things that place them at risk for falls, because they are too accustomed to their surroundings to view them as potential hazards. Older adults and their family members need to be aware of things that they can do to reduce the risk of falls. So some strategies to reduce the risk of falls include: first of all, it's very important to communicate fall risk to the patient, family, and staff. Fall risk should be communicated in the medical record, in handoff reports, signs on the door, and patient wristbands. Once a fall risk factor has been identified and documented, an individual plan can be developed and implemented to reduce the risk of falling. For example, studies have shown that falls are reduced when an individual engages in exercise focused on 2 or more of the following elements: balance, strength, endurance, and flexibility. Exercising in a supervised group, practicing Tai Chi, and performing individual exercises have all proven to be effective in this manner. Environmental modifications have shown to be effective in reducing falls in those at high risk, such as people with severe visual deficits. Such modifications and safety strategies can be found in box 9-2. The community-based older adult at risk for fall should have some sort of device to call for help in the event of a fall, such as a life alert. So preparing a safe surrounding, ensuring that there is adequate lighting, particularly in stairwells, keeping frequently needed items such as the telephone, tissue, at a table near the chair or bedside, considering a low-rise bed that's no more than 14 inches from the floor. Personal alarms and pressure sensor alarms alert nursing staff to patient movements as well. Ensuring in the environment that there are no throw rugs, uneven floors, electrical wires crossing the floor, oxygen tubing, or other items that could cause tripping. Mop up spills anywhere immediately. Avoid placing items on the floor. Encourage the older adult to not climb on anything other than an approved step stool to reach high places. Allowing adequate time to complete an activity or task. Haste increases the risk for falls or other injuries. If the older adult feels dizzy or lightheaded, encourage sitting for a while before standing. Encourage proper fitting footwear. Shoes with non-slip soles and low heels are recommended because high-heeled shoes contribute to balance problems. Shoes should have closures that are easy to manipulate. If shoes have laces, check that they do not come loose and cause tripping. Loose-fitting slippers or shoes can drop off the foot and lead to a fall. Encourage assistive devices when needed and the use of those assistive devices. Prescription eyeglasses enable the older adult to clearly see their environment. A cane or walker provides security with ambulating by enlarging the base of support. Keep these assistive devices close at hand to avoid leaning or reaching. The tip of the cane or walker should have a solid rubber grip to prevent slipping and may need to be modified on icy surfaces to promote gripping. Encourage the older adult to ask for help when necessary. Failure to seek help can lead to serious injury. Encourage older adults to recognize that good judgment is a sign of healthy aging, not a sign of weakness. Provide toileting assistance at a regular interval. Assisting the older adult every 2 hours can help reduce fall risks. Fall prevention is everyone's responsibility. Outreach sessions about fall prevention designed to meet the needs of older adults, their families, and anyone who has contact with older adults could be offered at senior citizen centers, libraries, businesses, and community colleges. Healthcare settings need to maintain current and complete policies and procedures for fall prevention. New employee training regarding fall prevention, methods for prompt reporting and investigation of all falls, and scheduled multidisciplinary meetings to identify problems and plan interventions should occur. The federal government enacted the Elderly Fall Prevention Act of 2003 to develop a national initiative intended to reduce falls. This act was designed to fund research, promote public education, and provide services proven to reduce or prevent falls in older adults. In 2009 and 2010, additional legislation designed to reduce the number of falls among older adults was passed. Legislation requiring training on fall prevention for long-term care workers has also been implemented. The Joint Commission has also identified fall prevention as a priority. In 2015, the Joint Commission included risk assessments upon admission, after a change in patient condition, after any fall, and upon transfer as part of its efforts. Overall evidence is emerging that fall prevention programs are effective across all settings. Assessment begins with identifying and documenting intrinsic risk factors that place an individual at high risk for a fall. The Morse Fall Risk is an example of a fall risk assessment that might be implemented. If the patient is found to be at risk for falls, more frequent assessments must be performed and documented. We move to fire hazards. Hospitals and long-term care facilities are well aware of the dangers of fire. Older adults are among the highest risk group for injury or deaths caused by fire. Building codes for institutions such as long-term care facilities, require safety doors, fire extinguishers, exit windows, oxygen precautions, and other safety measures. Each institution must have a fire safety plan designed to reduce the risk for fire, a quick notification system to the local fire department, protocols for fire containment, and an evacuation plan. Please review RACE and PASS. Within the home, studies show that over 1,000 Americans over the age of 65 die each year as a result of fires. Residential fire injuries on average there are on average 3,000 older adults each year that are injured in residential fires. Most fire injuries are the result of cooking accidents, whereas the majority of fire deaths are smoke-related. Many of these deaths could be prevented by instituting basic fire precautions. An external factor that presents risks to older adults is extremes in environmental climate. Older adults in extreme conditions, a temperature below 60 degrees Fahrenheit or above 90 degrees Fahrenheit, are at increased risk for developing problems related to thermal regulation. Thermal regulation is the ability to maintain body temperature in a safe range. It is controlled by the hypothalamus. The normal core body temperature is maintained between 97 degrees Fahrenheit and 99 degrees Fahrenheit. Body temperature can be affected by numerous internal and external factors. Internal factors include muscle activity, peripheral circulation, the amount of subcutaneous fat, metabolic rate, the amount and type of foods and fluids ingested, medication and disease processes. External factors include humidity, environmental temperature, air movement, and the amount and type of clothing or covering. Older persons who are sick, frail, inactive, or take medications that prevent the body from regulating temperature normally are at serious risk when exposed to even minor temperature or climate changes. And box 9-6 includes some of those risk factors. Even active, healthy, older adults are at increased risk when exposed to extremely hot or cold temperatures. As the cost of heating the home increases, older adults may try to save money by lowering the thermostat setting. This can be dangerous because a drop in environmental temperature below 65 degrees Fahrenheit can result in hypothermia for older adults in their 80s and 90s. Likewise, air conditioning costs are considerable, and many people may be reluctant to use this even when available. So what are some of the thermal hazards for older adults? They include the following: exposure to excessively cold or hot environments. We've already said limited financial resources to pay for heat or clothing that is suitable for environmental temperatures or to warm their home. Neurological, endocrine, or cardiovascular disease. Hypometabolic or hypermetabolic disorders like diabetes, cancer, hyperthyroidism, malnutrition, and obesity. Infection or other febrile illnesses. Dehydration or electrolyte imbalances. Inactivity or excessive activity. Temperature-altering medications such as alcohol, antidepressants, barbiturates, reserpine, benzodiazepines, phenothiazines, and anticholinergic drugs all have thermal hazards for older adults. So let's talk a bit about hypothermia. Hypothermia is defined as a core body temperature of 95 degrees Fahrenheit or lower. Older adults are highly susceptible to hypothermia for several reasons. Normal changes that occur with aging affect the body's ability to regulate temperature. Changes in the skin reduce the older person's ability to perceive dangerously hot or cold environments. decreased muscle tissue, decreased muscle activity, diminished peripheral circulation, reduced subcutaneous fat, and decreased metabolic rate affect the amount of heat produced and retained by the body. As a person ages, metabolism slows, activity decreases, and shivering diminishes. When exposed to low environmental temperatures, body temperature drops further. These changes further decrease activity and heat production, allowing body temperature to decrease even further. If the cycle is not stopped, death may occur. The National Institute on Aging estimates that more than 2.5 million older adults are at risk of hypothermia, and the CDC reports that approximately 700 deaths per year are attributed to exposure to excessive cold. This slide presents the signs of hypothermia. Hyperthermia is a higher than normal body temperature. It occurs when the body is unable to get rid of excessive heat. Deaths directly or indirectly caused by hypothermia average about 700 per year in the United States. Men die from hypothermia about twice as often as women. Most hypothermia deaths occur in adults over the age of 50. Hyperthermia can be caused by excessively high environmental temperatures, an inability to dissipate heat, or increased heat production caused by exercise, infection, or hyperthyroidism. Many parts of the country experience extremely high temperatures during summer months. When this heat is combined with high humidity, the normal cooling mechanisms of the body are inefficient. Even under moderate condition, it takes longer for older adults to begin sweating. And because of diminished thirst and decreased body water, they produce less perspiration. These factors render older adults more likely to develop heat exhaustion and heat stroke. Hypothermia can place a significant strain on the heart and blood vessels of older adults. Cardiovascular problems and heat are deadly combinations. Endocrine problems such as diabetes and psychiatric disorders also increase the risk for hyperthermia. Medications commonly used by the older adult can compromise the body's normal adaptation to heat. Diuretics prevent the body from storing fluids and can diminish superficial vasodilation. Anticholinergic medication used to treat Parkinson's disease can interfere with perspiration, as does a wide range of psychotropic medications. Consumption of alcohol should be avoided because it can decrease awareness of symptoms and contribute to fluid loss. Symptoms of hyperthermia are progressive. Mild early signs of heat stress include feeling hot, listless, or uncomfortable. Cramps in the legs, arms, and abdomen are early indications of elevated body temperature. Indications of serious heat-related problems may include hot, dry skin without perspiration, tachycardia, chest pain, breathing problems, throbbing headache, dizziness, profound weakness, mental or perceptual changes, vomiting, abdominal cramps, nausea, and diarrhea. Heat exhaustion occurs gradually and is caused by water or sodium depletion. Both active and inactive older adults can develop heat exhaustion if they do not consume adequate fluids and electrolytes when exposed to hot environments. If heat exhaustion is not recognized and treated, it can progress to more serious conditions called heat stroke. Heat stroke is a condition in which the body temperature can climb as high as 104 degrees Fahrenheit. It is a life-threatening emergency. Heat stroke is a very real concern for active older persons, particularly those living in hot climates. Strategies that can prevent or reduce the incidence of hyperthermia are listed under nursing interventions in each of the nursing process sections. Page 18, or this page, lists interventions for those with hypo or hyperthermia.